Welcome to Impactful Chats. I'm Maylyn Martinez,
And hi, I'm Seth Trueger.
and today we are talking with Dr. Ali Khan. Um,
Yeah,
Hi, Ali. Why don't you start by just telling everybody a little bit about yourself?
it's great and super great to be here after longtime listener, first time caller to Impactful Chats. I am a general internist on the west side of Chicago. I work at Oak Street Health in East Garfield Park, where we take care of highly vulnerable, structurally marginalized seniors and other Medicare enrollees in a lot of Chicago's primary care deserts. So it's a high touch, high intensity primary care model where we get to do a lot of like neat things to try to keep people from crossing over the Rubicon to get to Seth's ER is pretty much the big goal. So I am the executive medical director at Oak Street. I dabble in a lot of other things. I am still a part-time clinical hospitalist at the University of Chicago, along with Maylyn, and I am the chief policy officer at Impact.
That's a lot of titles. Yeah, that's an important thing to mention, actually. You're actually one of the Impact co-founders.
I am the sole guy. Since Seth refused to be a co-founder, it's just me.
Did I refuse? Is that right?
Unclear.
Seth, you hold an important position at Impact too, though.
Yeah.
You're the digital media advisor
Oh, sure. That sounds right.
/ webcaster with me. But so Ali, we have you here today because you, first of all, you had recently been vaccinating seniors at your clinic on the west side of town, like you said, and you had some interesting experiences with that sort of enlightened you in a way that you didn't expect. And you've written some interesting op-eds in the Tribune sort of related to your experience with that. So what did you learn from that experience vaccinating seniors?
So it's been a really interesting experience. And I'll step back for a second and say, I've gotten to see a few different flavors. So one, like obviously we vaccinated our own employees, and there's like a whole podcast we could probably do to talk about, broader issues with vaccine hesitancy even among healthcare workers. But I think the second thing that became prevalent, at Oak Street, we over the past few weeks, we've vaccinated about like 5,000 1A healthcare workers that don't work at Oak Street, right? So home healthcare workers in the south side of Chicago that aren't affiliated with anyone, physicians who have like a single practice, like kind of like you were rotating at as a family medicine student, dentists, lots of dentists from all over, lots of behavioral health specialists, school nurses, therapists, and seeing like a really interesting factor of institutional affiliation, kind of as like the unintended health disparity of people who want vaccine access, who are like really dying to get it, but couldn't figure out how to navigate a system. I think now as Oak Street has moved into vaccinating seniors, and we've vaccinated about 10,000 seniors and about 15,000 people all in as of this evening. It's really clear that there are a lot of seniors, even in like majority Black and brown neighborhoods, right, who are actually very eager and excited to get the vaccine. And there's certainly widespread hesitancy as well. But the trick is more that they have to figure out how to get access, right? So like that, the disparities from a technological perspective, right? Like for all of us, like putting, signups in MyChart or in like Oak Street's EMR system, going through web portals and the like, really highlights obviously the challenges around people who don't have reliable internet access, right? Who don't have reliable broadband, or who like having language barriers from an English language perspective and can't navigate these websites to begin with, much less the trauma, the real trauma of hitting refresh on a vaccine website run by a county or run by anyone to try to get an appointment for someone, right? So you add all that together, and we've just found that taking more of a multi-channel approach of hitting the ground running with community-based partnerships that we work with has an effect of incentivizing people through word of mouth to sign up for a vaccine, calling them proactively if we have their numbers, and texting them proactively, whether in Spanish and English and Polish and Mandarin, right, can be very useful in terms of getting people to give the information needed for them to sign up. I think most crucially for us, paying for people's rides has been a really big differentiator. So either for our patients, we always pick them up for appointments anyway in our like fleet of green vans. But for a lot of patients and a lot of seniors, we're actually giving out Lyft rides, as is the city of Chicago with Lyft and with Uber, to give people free transportation to and from appointments, right? So it's like, I kind of bucket all of this into sort of like, these are the last mile challenges of like, we developed a vaccine in record time. We think we know it's safe. We're getting it into people. But to get into a population that's not as connected as us, like us as physicians or healthcare workers, we've got to do more to make sure they can actually cross that, that last stretch of challenges before getting to the vaccine itself.
This is just amazing. I feel like I'm reading like the fishbone diagram someone made, and you like fix all the steps. That's just great. So what have you been seeing in terms of vaccine hesitancy?
So it's been really interesting, right? I think that from a vaccine hesitancy perspective, the disparities are far more aligned around age, education, and like role, even among healthcare workers, right? Like, so, I mean, I think obviously we knew going into this that we would anticipate higher vaccine hesitancy among Latinx and Latin populations, right? We expected that to be the case. We expect that to be consistent across the board. From physicians, nurses, and like dentists and the like, right? Black physicians and Hispanic physicians are engaging in equal measure. But from the opposite side of things, right, around, thinking around like Black MAs or Hispanic welcome coordinators and front desk staff or phlebotomists who are young and, young invincible, right, from a policy perspective, they just aren't as interested in engaging from a vaccine standpoint, right? And even they may be working in healthcare, they may have been, hi Frost, super excited around, getting back to work, getting, getting the right kind of PPE, those sorts of factors. But they've never really wanted to get the flu vaccine. And they're not engaging with the COVID vaccine either. And so with that population, we found that we have to move slow, right? This is going to take time. It takes trusted messengers. It takes time for us to build that volume. And I think that's true a lot of our health systems around Chicago, where we all saw, 50 to 60% acceptance. I think what would be curious is to pick up on this now and compare across the same health systems. Has that actually moved at all or not, right? I think our hypothesis was that the more people that we got vaccinated, the faster this would move. I think we're seeing some of that from a community standpoint, but among healthcare workers themselves, it's been a challenge. And so, is it that it may not be that getting the three of us vaccinated will do enough to move my MA, but maybe it means that vaccinating his community faith leader will actually do something, right? So like, this is where 1B may be able to help 1A, but I think the jury's still out.
Yeah. What exactly, I think you touched on just a part of this just now, but what exactly did you mean when you were in a press conference, I think about vaccinations with Mayor Lori Lightfoot, Mayor of Chicago, and you said, we need to move fast and slow for maximal impact during that press conference. What exactly did you mean by that?
Good memory. So your call has been sorry. One sec.
It's real life.
This is my son who Frost knows, so I apologize. Who Seth knows, not Frost.
I think Frost knows him too, but
yeah, Frost hopefully. So point being that when we were talking about fast and slow, I think this was coming at a time where for a lot of us, there was a big conversation around like, okay, we fixed 1A, right? Like we got our own staff vaccinated. Let's move on to 1B as quickly as possible. As I hide in my house. But like, I think the challenge was at the same time that we were seeing this, we were still seeing, yeah, we can move fast. We want to move along. But like the demand from a healthcare worker perspective, the people who were not affiliated was enormous, right? Like the city and the counties in and around Chicagoland were telling us each institution had lists of tens, if not hundreds of thousands of people who were raising their hands for the vaccine. So in that context, right, like rather than taking an institutional specific approach around saying, all right, we got X percentage of Northwestern or Y percentage of Loyola ready, we want to say like, we actually have a huge, we can be coming together as institutions to actually manage this and vaccinate a bunch of people in 1A who need our help. Let's go fast with them, right? Let's do the same with 1B, because we know that there's vaccine hesitancy that exists in 1A and among healthcare workers. We know we'll encounter that in 1B. We have to drive fast towards herd immunity. But like, if we don't actually commit to doing the work slowly of 1B at the same time and put that in equal measure, then we're going to actually fall apart. And I still think that's true.
So when you say the work, like things like the outreach, the phone calls, the getting the 1B appointment 2 weeks from now that you need, or you still finish up 1A, that kind of stuff?
Kind of. I mean, I think that like when even just 2 weeks ago, right? 3 weeks ago when we were contemplating this, there's a large sort of sentiment around we've gotten who we can among 1A, right? So everybody else is vaccine hesitant. We'll come back to them later. Like, let's move to 1B. That was a very institutional specific viewpoint that on some level ignored like the mom and pop physician shops or the dentists or everybody out there, which suggests whose need that had been unmet. Suggested we still had a lot more people we could move fast with, right? We weren't necessarily ready to go to 1B because of like the huge, hundreds of thousands of people in greater Chicagoland who could have continued to be vaccinated. And thankfully now, like a lot of other institutions have stepped up to do that work of vaccinating other 1A workers who don't necessarily work for them. But at the same time, like, so we were presenting a false dichotomy, right? Like we got to 1A, we did our own people. So now it's time to move on to our patients in 1B. When in reality, right, like this is somewhat symptomatic of not having super strong public health infrastructure, right? A cohesive strategy where all the major organizations and, the community organizations that are doing healthcare delivery, that are doing vaccines in Chicago, committing to saying, hey, let's you've got this whole list. All right, Rush, you take this part. Northwestern, you take this part. Oak Street, you take this part, right? Esperanza, take another part. Let's figure it out together. Would have actually done the work of saying, let's continue to push through where there's clearly, obviously pent up demand. At the same time, let's listen to the work of going slow, really investing in, cross-sectional, cross-community partnerships around vaccine hesitancy, like Chicago's Vaccine Corps and the like, and commit to doing that work thoughtfully, as opposed to sort of just giving it lip service. We saw, 100,000 op-eds, but how many people are actually doing that work in communities? That yet remains to be unseen.
Right. And can you kind of explain to people also how you saw what the sort of digital divide was doing to worsen sort of disparities that we were already seeing with who was getting the vaccine?
I can't. Give me 1 sec. Sorry, I have a lot of kids and they're very rambunctious, Maylyn. So
I think this is one of the realest episodes we've ever had. I run away too and put my dog away.
Yeah, exactly. So I think from the context of the digital divide, I think that's played a fairly reasonable role, mainly because, again, it comes back to the same question I think faced our 1A workers, right? Of people don't know where to go, right? It's information asymmetries that are coupled with digital access asymmetries that come together to say, if you can't get in on the internet in the first place, you definitely aren't going to figure out where to look, right? But even if you can get on the internet, and then you're not sure how to navigate a fractured system of hey, I heard there's an email at U Chicago that I can access to get this, versus this Facebook group told me something else. We actually saw social media, right, fill in a lot of the gaps for people when we assumed that everyone had good internet access, right, among the 1A population. But now as we get to 1B, we realize this is much more nuanced, right? The dependency that we built quickly in 1A around internet access and tools is actually stymieing our progress now, because a lot of us are seeing hey, we sent out 30,000 MyChart appointments, and we got a 10% response rate. We don't use Epic, but I'm just that's what I've heard from a health system. And so it's well, how many people actually got that email? If you were targeting zip codes on the West Side, unclear, right? So it just becomes if we can get information into the hands of seniors, 1B essential workers, minority communities in ways that they can actually act upon, we will get the response that we hope for, right? We can push out, 20, 30, 40, 50,000 doses a week, like what, Chicago's getting from a supply standpoint. But if we can't do that work through thoughtful multi-channel collaboration, doing not just internet, but all these other things, including face-to-face in a safe manner, then we're just gonna we're going to continue to keep skimming the cream off of this huge jug, right? And we keep doing this over and over again. And until we get to more intentionality, which I think the city is trying to drive towards with differential vaccine access distribution, targeting, we're saying very clearly, hey, here's a strong Latinx community in Little Village or in Belmont Cragen. So we're going to, divert 6,000 doses to those two communities, right? Which means that we may not have as many to give, Northside Clinic X, right? And that we think that's okay in a place where we have, constraints on supply. We can do a lot of those offsets, and I think that's part of the solution, but it's a one solution in many, which really gets back to like, how are we communicating this and how are we making this really easy for people to not only sign up for that appointment, but then get to that appointment, get the vaccine, and then get that second appointment.
Yeah, so one of the things I think that dovetails with all of the digital channels you've mentioned is, someone described this really well. It should be like getting Hamilton tickets. And one of the other aspects is can you explain what's the problem, the first come, first serve strategy for getting these appointments?
So again, I mean, it's like that it predicates itself on privilege, right? If I'm able to work at home with reliable internet access, I can get up at 6:45, like hunker down to my scrubs and, start refreshing a page as I prepare for telehealth at 8 a.m., right? Knowing that page is going to open at like 7:15. If I have to take 2 buses to work from the north side to the far west side, the likelihood of me being able to hit refresh on that page is automatically lower, right? Just by sheer distractibility of terms of like trying to navigate things, get on life, worry about somebody coughing in my face and I don't have the right mask, so on and so forth. And so first come, first serve can be effective when you've got a relatively homogenous population with homogenous access. So like when Seth and I are going against each other to sign up for our daughter's, Taekwondo class at school, that is reasonable for us to be first come, first serve. And that's why I've lost every single time, because I always click Bollywood dance first. That's my problem. When it comes to like vaccine access, where there are people who are actually differentially worse off if they don't get the vaccine versus like me probably not being that worse off for Taekwondo class, it actually, the way in which we do this actually matters. And I think, a lot of the health systems have put in real effort, I think Chicago in particular, around saying, what's the ethical framework that we use around, initial prioritization for invitation. But now it really gets into doing things like what DC is doing, which says, hey, the first 2,000 spots, you have to live in these zip codes. And if you don't live in these zip codes, you're gonna be kicked out of the system for 24 hours. Like, that's a powerful impediment. That now, again, it's still dependent on an internet-based system, but that coupled with proactive call center outreach, right? Staffed by medical students, like what they're doing in DC and West Virginia, or the kind of work that we're seeing in, emerging other cities or across the country that say like, how are we signing people up using paper, right? Like there's the analog method to this that actually still works. And so I'm not suggesting it's the only way, but I think many of us out there are realizing it's got to be one in a series of complementary activities.
Right. Well, Ollie, thank you so much for being here with us tonight. I think that this will explain a lot to people about how, in spite of everyone's hard work to get the vaccine made and ready so fast, why we're experiencing these bottlenecks now. But yeah, so thanks for joining us tonight.
Thanks for all you do, guys. This is a lot of fun.
Yeah, thanks. Take care and stay safe.
Bye, guys.